It's my first time at this meeting, and I'm really glad to be here. So I've been asked to tackle the issue of HIV&Aging and in LMIC, but instead I did request that I focus on Africa, just to keep it focused. So this is the outline of my talk. I will try just to give you some background and try to go look at how the risk factor looks like and the clinical presentation in the African context. But I'm going to share with you also some really non-traditional risk factors that are not relevant, are emerging from some setting, and then tackle some important issue which came up also at the NIH comorbidity meeting about 2 weeks ago, and just highlight a few research agenda and conclude. So as you all know, we're making quite a great progress in the global HIV epidemic, and it's really exciting time in the event of antiretroviral therapy. We're gaining in terms of survival. This has been well documented in the West, but we also been able to document it in Sub-Saharan Africa. As you know, majority of HIV-infected individuals live in Africa, about 70% of them. So that way, really the bulk of the epidemic is. And thanks for PEPFAR, really remarkable increase in access to antiretroviral. And majority, again, is in Sub-Saharan Africa because of just the bulk of the epidemic there. That correlate is associated with really dramatic decrease in mortality, as you can see there. But that was a global picture. But try to focus on how the sharp decline happened in Africa. You can see it even more really sharp compared to other settings. Is to tell, really, it tells the story that really antiretroviral is saving life at a really dramatic level. And that also explains why the life expectancy that was really stopped, reverse because of HIV, now is coming back again. And that, again, speaks to the impact of antiretroviral. But just stop talking, just look at the picture. It speaks by itself. Antiretroviral is being really a game changer. You still recall this slide that was circulated over and over again from, this is a patient in Haiti from the group, the Harvard group working there. So people can go back to school, can think again, getting married, take care of their children. So this has been really remarkable. So again, then the downside, I'm not sure if I can say it, the downside, but the point is modeling data showing that as now people living longer, obviously the high prevalence of HIV is going to increase in older people. And as modeling data show here over time, what is going to show happen in Africa. And they actually, looking at data from South Africa, it shows really stratified by gender, how this is going to look, increase of HIV prevalence in older group. And that also correlate with comorbidities, here hypertension, diabetes, and disability. And this is a recent, really remarkable paper published by Shine Circulation, showing the population attributable fraction of CVD due to HIV is the highest in Sub-Saharan Africa, which makes sense because that way the bulk of the epidemic is. And if you want, as epidemiologists, we would like to put some odds ratio. So overall estimate of about two time increase in smoking, lipid abnormalities, diabetes, and hypertension compared to a group control. And this, the epidemiological transition, which has been known for a long time in the West, Europe, and United States, is happening also in the background in Africa. So this is, Chris Murray global burden of disease data showing, just looking at Ethiopia, the most cause of death, just look, HIV coming down, but look at ischemic heart disease, really the sharp increase is almost the second now. So what the data we have there in terms of those comorbidity as people, HIV are aging in the African context, let me just start by saying data are very limited. Surveillance and community-based surveillance are lacking. Systematic review, the one that are available, for example, for hypertension, give the range between 5 to 45, diabetes mellitus 0.9 to 28, metabolic syndrome about 2 to 20, and so this is quite a wide range. So you may ask, why such a high range? It may be explained by difference in methodology, it can be sampling, definition, difference, access to health care, or other unmeasured factor. But the point is there, we really need more high quality data, both for facility but also community-based measurement. But just to give you some glimpse of some data that had been published here, and I think this is quite going to be interesting, you as a European or United States clinician, while you experience those comorbidity mostly, we're still experiencing, clinical case like HIV cardiomyopathy or pericardia effusion, which are kind of for pre-art era type of comorbidity, CVD comorbidity that were occurring in the US. But those in African setting, people presenting late, very low CD4 count, so you're still having those majority cardiomyopathy, things that are no longer happening in the West. And in terms of the risk factor, so the traditional risk factor, dyslipidemia, diabetes, hypertension, smoking, so those are well known. The HIV specific, there were eloquent talk today talking about that, just looking recently with Jason talk earlier this afternoon. But my point here is to say we cannot just extrapolate what has been found here in an African setting. And there may be some genetic factor that are specific for Africa that as an investigator working there, we need to start to look at, or some just other environmental factor that are not here. And also some co-infection like how malaria, TB, helminthes, parasitosis, how they are affecting this inflammatory pathway and causing those comorbidity. All that we don't know. So there is quite a lot we can learn which are specific issue relevant to low and middle income country. So all this is also happening in Africa, but I'm not going to talk about these traditional risk factor. I would like just to highlight one of the paper of my postdoc in Democratic Republic of Congo, looking at biomass cooking exposure, and which show definitely this is an exposure that is not really common in the West, but which has been shown to be associated with cardiovascular diseases. And it affects actually the systematic inflammatory pathway and is being shown as an emerging specific non-traditional risk factor in those settings. And also looking at Peter Hunt's group work in Uganda, in Mbarara, they've been able also to identify a polymorphism that disturb the tryptophan pathway and which at the end increase the risk by increasing the KT ratio, increasing the risk of atherosclerosis, depression, AIDS-related cancer, which was Kaposi sarcoma, and all-cause mortality. So this is a regional risk factor that is not known in the US, which is relevant in those settings, and I think this is really interesting to see. So, and I will stop there, I can continue, but in interest of time, I just want to highlight some really key important points. So I think this is just drawing from the geriatric syndromic approach, I think we need to conceptualize different this dynamic of comorbidity in HIV in developing countries, especially in Africa, by trying to integrate some, not only when you look at quality of life, not only just the physical functioning, but also the cognitive functioning, but also the social functioning. And when I say, and to be comprehensive, include some, social factor, which can be issue in terms of taking care of orphan or stigma, which are issues that have different dynamic there. So you can include also other kind of social, biomedical factor and HIV-specific factor. So, but I think it's time to rethink, and this is just the beginning of new work to come. So this is really, the health system in those settings are so weak, and this population is growing, and now the priority is how we can tackle the growing burden of non-communicable disease in HIV setting. And I think here the point is let's not reinvent the wheel. Why not, thanks to PEPFAR again, they did really dramatic work to try to expand access to antiretroviral and saving lives. We can use the infrastructure of PEPFAR in those countries to try also to screen, manage, and prevent non-communicable diseases. It's a no-brainer. And those, both HIV and NCD, they have similar, framework for cascade: prevention, diagnosis, enrollment, disease management, and palliative care. It sounds like easy to do, but I can tell you the devil is in the detail, and there is different model. Either you keep them parallel, this may work in some setting, not the other, or you just integrate a part of those two services, or you do a full integration, that the third model on there. So there have been some organization that has been looking at this, but I have to tell you, you need to look at what the feasibility, what the acceptability, efficiency, and equity. There is also issue, what the impact going to be. You don't want really to have counterpart consequence. So I think this is an important area where we need to start to think how to integrate. And at the time I'm talking now, there is several organizations from, I can say, Médecins Sans Frontières, ICAP Colombia, or other organizations which are working on this path in several countries, from Zambia to Mozambique to South Africa. And the idea is they're providing both HIV but also hypertension. They provide diabetes, cervical cancer, asthma, COPD services integrated. I have to tell you, data are not yet there to see how this is working, but they're collecting. So we hope in the next year or two, we'll be able to share with you some hard data on how those integrated services are making an impact. Just to give you a few examples, this one is, I think, is in Malawi. So hypertension screening within HIV clinic, integration model. The next one is in Zimbabwe with Médecins Sans Frontières. This is a model which involving TB, hypertension, diabetes, asthma, so all chronic disease. And this is service are so integrated, not only HIV, and other NCD, at the point that they tend people to accept them because there is not the etiquette of HIV, so the stigma may be also reduced by people attending. This is in Uganda, a project led by UCSF, the project SEX, which they offer hypertension screening and linkage to care, diabetes, HIV, TB, malaria. The uptake has been shown to be quite very high, and this is also an interesting one. Those who are familiar with Nairobi, this is the slum in Kibera, where also this type of integration is happening. So I think you see this is happening, and we hope we can make a difference by try to detect, manage effectively those comorbidity efficiently. But there is I did select a few research priority for us to think of. And the first one is, obviously, as I've been begging, we need data, we need hard data. There is need data on determinant of health and the quality of life among people living with HIV in Africa as the epidemic is aging. We need formative work that consider relevant domain of geriatric health, such as independence, functioning, and social well-being more broadly, and which account for locally adapted future of quality of life. This has been neglected, and I think it's important. You cannot just extrapolate context from the West in those settings. We need biomedical, psychosocial, environmental determinant of health and quality of life, which also has been lagging. We really need some mechanistic research, just looking at as I said, there is so environmental or co-infection that may, make the physiopathogenesis a bit different from what we're experiencing in the West, which may also be relevant there in terms of when it comes to designing targeted intervention. But before we get to those targeted intervention, we also badly need prospective cohort study with control group, which will be able to help us. As in the West, you had those famous cohorts. We need similar cohorts in LMIC. One attempt is the PACT initiative, Partnership for Cohort Research and Training. This was an initiative of Harvard School of Public Health. In Uganda, Tanzania, South Africa, and Nigeria. These are the principal investigator, Jimmy Volmink at Stellenbosch in Cape Town, Clement Adebamoyo in Nigeria, David Guatude, Francis Banjunwire in Uganda, and also Marina Njeleka at Dar es Salaam. So those are the African PI and the US PI, Michelle Holm and Hans-Olof Adami at Harvard School of Public Health. So this is an initiative. They have some pilot data, but they've been struggling to get all the cohort taking off because of the funding. But this is the type of initiative we need. And this target NCD, they're going to stratify through HIV. I think it's some of the work we need. And also talking about money, this is a notice of intent to publish R21 mechanism to try to help us to start to collect some preliminary exploratory data in HIV and NCD. And recently, there was also this RFA, which is a EU mechanism, which has been posted also, which is going to help on getting some funding to move forward. You just put them there if you are interested. So in conclusion, I think to sustain the benefit of heart, as I just showed you, in Africa, there is a need really to increase research of determinant of health and quality of life. To date, most studies of aging with HIV in the region have been cross-sectional, have focused on a single morbidity domain. We really need to be a bit bold and to be comprehensive on how we approach this. We need to have determinant of quality of life which are relevant to the local context, and we really badly collect data which help us to understand the mechanism besides just the burden, the mechanism, so we can design really powerful targeted intervention that can improve the outcome of aging HIV population in those settings. So I'm going to stop there and happy to take any question, but I would like first to thank all my collaborators in South Africa, at University of Pittsburgh, at Johns Hopkins, and my funding from NIH mostly. And thanks also to my collaborator who give me some slides to present to you. Thank you very much.